Hello everybody. Over the next 25 minutes we will discuss the optimal imaging strategies for advanced prostate cancer using as a guide the ASCO guidelines for advanced prostate cancer. Here are my disclosures. We all know that prostate cancer is categorized using the clinical disease states model determined by the tumor characteristics, its radiographic extent on bone scans and CT scans, and on testosterone levels. So here are the typical prostate cancer states. You can see localized disease on the left-hand side and more advanced state here on the right. So high risk locally advanced disease is considered as an advanced prostate cancer state. If you treat that effectively, you might cure some patients. On the other hand, most oftentimes they develop biochemical recurrence, which is usually depicted as being non-metastatic on conventional imaging, but could have microscopic metastatic disease at next generation imaging. And of course that can lead to metachronous metastatic disease, either oligometastatic or polymetastatic. Similarly, you could have a high-risk locally advanced prostate cancer with synchronous metastatic disease, again oligometastatic or polymetastatic. And this can directly lead on to the castration resistant state, either oligometastatic or polymetastatic. There are multiple unique challenges in advancing disease because we're using bone scans and CT scans. So there are a number of states where you can have advancing or rising PSA levels and you don't see anything at all. Similarly, there are instances where patients are clinically progressing but you don't see anything changing on the conventional imaging. So there's a great deal of interest in identifying better imaging strategies to inform on the optimal management of patients with advanced prostate cancer, but so far next generation imaging has focused on just on diagnostic performance. And recently there have been a number of papers that have expressed an opinion that there needs to be better evidence on the impact of next generation imaging for the management of patients with advanced prostate cancer. So any imaging advances should better predict, prognosticate or enhance treatment decisions. So maximize treatment benefits, minimize undertreatments, reduce overtreatments, reduce toxicities. However, so far there's been incomplete evaluation of the management impacts of next generation imaging, as a result of which we are already seeing that patients are being subjected to treatment intensifications that may not improve overall outcomes. On the other hand, we've also seen patients de-escalate their therapies, which may in fact lead to undertreatments, increased morbidity and mortality. In other words, we need study designs that evaluate next generation imaging to more properly evaluate the management and survival impacts in advanced prostate cancer. So what are the advantages of next generation imaging? Well, two advantages. It improves detection sensitivity. So at staging, this is microscopic metastatic disease. During therapy monitoring is microprogressive disease. And of course the other advantages is it improves response categorizations in bone disease. But there are a number of biases: stage migration, length time, and lead time bias. And we're just going to look at stage migration bias and lead time bias for the moment. So on the right hand side you can see a number of PET traces. You can see they all have a better detection sensitivity than the bone scans, and because of that, if you have a patient with locally advanced M0 disease on CT scans and bone scans, they will often become oligometastatic. And if you see oligometastatic on bone scans and CT scans, they're often polymetastatic. And this ability to identify disease at an earlier stage because of increased detection sensitivity can lead to something called lead time bias. So here, for example, is conventional imaging. If this is the time that you detected a disease and this is the overall survival, if you use next generation imaging, of course you detect it earlier, improved detection sensitivity. If you use the same treatment and they live just as long, then this improvement in survival here is just lead time bias because the overall survival does not improve. Another advantage of next generation imaging is in response assessment settings, as I've just mentioned. So conventionally you would divide patients into progression and non-progression categories, and remember, progression categories tend to be major progression before you can see it on next generation imaging. Next generation imaging helps you split this apart so you can distinguish response from stable from progression. And of course, within progression, minor progression or microscopic progressive disease and major progression can be distinguished. So similar to lead time bias, you can get lead time bias affecting the response assessment paradigm. So in conventional imaging, if this is when you made the diagnosis, this is your first treatment, that's the time when you see progression, and then you institute treatment number 2. Okay. If you do next generation imaging, you'll see micro-progressive disease earlier. So this point comes here. But if you use the same treatment and they just survive just as long with the second therapy, then this is lead time bias within the response assessment paradigm. However, if you are able to use a treatment such as metastasis-directed therapies, for example, and then use a treatment they were going to use as a third treatment, then it's possible to push this out, because you reset the clock here to this point and then you use the treatment here, and so the overall survival time improves. So for all the advanced prostate cancer states, the guidelines say that you should do some sort of imaging depending on clinical scenario, either conventional imaging or next generation imaging. When you're trying to choose which one to do, you need to take the scenario into consideration, because the imaging modality may guide treatment or change clinical decisions. But if you're not going to change treatment, or the prognosis will not be changed, then next generation imaging should not be offered. Let's start our discussion by looking at biochemical recurrence and biochemical persistence. Here's a man who has PSA persistence shortly after prostatectomy, and you can see the PSMA PET-CT scan shows a right internal iliac lymph node. How common is this, and does it relate to the PSA? Yes, it does. You can see here we've compared fluciclovine with PSMA, and you can see that when PSMA levels are low, less than 0.5 nanograms per ml, in about half the cases you will see a focal area consistent with recurrent disease. And clearly, as the PSA level increases, and on the right hand side you can see it's above 1, you can see an increasing proportion of patients with PSMA positivity, but a significant difference when compared to fluciclovine. So what do the guidelines say? Well, the guidelines say the goal of therapy and the potential use of salvage therapy should be the guiding choice about the use of imaging. So if you're thinking about using salvage therapy, then you should be offering next generation imaging, ideally PSMA PET-CT, but choline, fluciclovine, if they're available, as they have a superior detection performance compared to bone scans and CT scans, and may alter management. And this was borne out by this systematic review that looked at about 2,000 patients. And you can see there was a change in management in about 45% of patients. The interesting thing is how the proportion of men undergoing a target therapy increased. So initially you can see before PSMA it was estimated that about 30% were scheduled for a targeted therapy, and in the end it turned out to be 64%. So, for example, here's a man in whom there's a single focal lesion, this time in the left pelvic side wall, and all the other pelvic lymph nodes that you can see on this diffusion sequence, for example, are PSMA negative. But how confident are we that that is the only lymph node involved and should be treated with CyberKnife or focal radiotherapy? Well, that depends on the sensitivity compared to a surgical series. Now, when you compare PSMA for lymph nodal disease in surgical series, you'll see that its sensitivity is only 40 to 60%. And you can see that over here. Indeed, it looks as though the smaller lymph nodes, less than 4 millimeters in size, are consistently being missed. So how do you deal with what you don't see? Well, the high rule-in ability, because of the high specificity, let's go back and look at the specificity. You can see that the specificity and positive predictive value are very high. The high rule-in ability means that it provides a target. So if you're going to use a particular treatment and you see something that's outside the field, then you can use it to extend the radiotherapy. In other words, escalate therapy beyond the normal treatment boundaries. However, the rule-in ability is, as we said, only moderate. The sensitivity is between 40 to 60%. And that means that regional approaches are preferred to lesion approaches, and you must consider using adjuvant treatments if you are going to do only targeted therapy. So putting that together, if you're going to do a lymphadenectomy, you want to think about doing a more extended dissection than a limited dissection. For pelvic radiotherapy, you may want to use pelvic side wall rather than focal therapy. And let me show you some data that supports that view. So here is a large study. You can see that 309 men received stereotactic radiotherapy and about 200 men received pelvic sidewall radiotherapy. And when there was only one lymph node visible on a PET scan, fluorocholine or PSMA, you can see that if you had stereotactic radiotherapy, then your disease-free survival, which is here, is actually less than if you were to treat the pelvic side walls. But if you had more than one lymph node, then you might as well have done either one because the disease was already out of the pelvis. Next, let's look at high-risk localized and high-risk locally advanced disease. Here's a man with a small right apical tumor that is high risk because of the high Gleason score. You can see that he was NX because he had a borderline lymph node in the left pelvic side wall which was PSMA positive, and in fact there were two other lymph nodes that were PSMA positive. And this was evaluated recently by the PRO-PSMA study, which showed that if you compare PSMA to conventional imaging, then PSMA had a 27% greater accuracy, it had a lower radiation dose, had a better report of variability, and caused treatment changes in a substantial proportion of patients. The guidelines say that when conventional imaging is suspicious or equivocal, then you can use next generation imaging. And here's a patient with high-risk locally advanced disease in whom we use next generation imaging. So here is the morphological images, and you can see this shows that the tumor in the midglandular region is PSMA avid, but you'll notice at the base it's PSMA non-avid, although we biopsied the seminal vesicle separately and showed that there was Gleason 9 cancer here, and this lymph node here on the high B value image was in fact PSMA negative. So again we come back to this graph that shows that the sensitivity of PSMA for small lymph nodes is only 40 to 60% in surgical series, and we talked about this in the prior BCR section. But are these small lymph nodes important? Well, here is a series of patients that were with high-risk locally advanced disease that were treated with either prostate radiotherapy alone or prostate and pelvic sidewall radiotherapy, followed by adjuvant ADT for 2 years. These patients were node negative on PSMA PET-CT scans. When you follow these patients up over time, what you notice is that the distant metastasis-free survival in patients who had prostate and pelvic radiotherapy was better than if they only had prostate radiotherapy. Similarly for disease-free survival, similarly for biochemical-free survival, but not yet for overall survival. So what we're saying is that the high failure rates of only prostate radiotherapy in PSMA negative patients, in these people who are at high risk, is clinically important once the effect of ADT has worn off. So ADT is working for a couple of years. Once you stop it, then you begin to see the failure. So these lymph nodes are important from a survival perspective, but you have to look for a longer period of time. So the summary is that PSMA CT is better than conventional imaging. There's no doubt about it, and the PRO-PSMA study shows it. It's more specific than conventional imaging, so if you're suspicious, then you should use PRO-PSMA. But PSMA PET-CT misses microscopic metastatic disease with long-term survival detriments if you don't take the lower sensitivity into consideration. In other words, treat PSMA PET-CT negativity with caution. Do not use PSMA negativity to limit intended nodal therapies. So what do the guidelines say about the use of next-generation imaging for treatment planning of patients with locally advanced disease? First of all, it says make the decision on the basis of a bone scan and a CT scan. Okay, but you're not going to repeat bone scans and CT scans if you've already seen high volume disease on a next generation imaging technology. So the way we approach this is to say, well, if you've done next generation imaging and there's high volume disease or there's visceral disease, then you should treat for metastatic hormone sensitive prostate cancer, which we'll come to, and the use of pelvic radiotherapy depends on what the MDT decides. However, if you have no metastatic disease, or you have only pelvic lymph node disease, or you have low volume disease seen on next generation imaging, then you should go ahead and treat the pelvis with pelvic radiotherapy and obviously adjuvant ADT. So here's an example of a person I saw recently. You can see locally advanced disease, a single lymph node in the left pelvic side wall, and a whole body MRI that shows no metastatic disease. In his case, what we said was the appearances are consistent with a locally advanced prostate cancer with T3A and T3B disease. There's an abnormal lymph node in the left internal iliac region, no bony metastases. This patient would be suitable for pelvic radiotherapy / ADT as there is no high volume metastatic disease. Next, let's look at hormone sensitive metastatic disease, which can either be metachronous or synchronous. Currently we use CT scans, bone scans and morphological MRI to divide patients with hormone sensitive prostate cancer into lower and higher risk. So you can use the latitude definition, the charted definition, or the Stampede definition. The Stampede definition is perhaps the most simple, relies on imaging alone, and you can see more than 4 bone mets or visceral deposits make somebody having a higher risk, and if you have less than 4 bone mets or node-only metastatic disease, then you are at lower risk. So here's a man who looks like he has low volume, low risk, metachronous, metastatic, hormone-sensitive prostate cancer. He seems to just have a few deposits in the axial skeleton. However, if we do next-generation imaging, you can see he has high volume, high risk, metastatic disease with a spinal cord compression. So this is an example of stage migration that we discussed previously. So he's gone from a de-escalated therapy to an escalated therapy, and in fact he got ADT plus docetaxel therapy. And this is the only indication recognized for the use of next generation imaging by the ASCO imaging guidelines, where you can use next generation imaging to upgrade patients from lower risk to higher risk, negate some of the treatments that you might have used for lower volume disease. So what do the ASCO guidelines say about the use of next generation imaging for polymetastatic disease in hormone sensitive prostate cancer? It continues to suggest that you should use bone scans and CT scans for therapy monitoring. It does not recommend the use of next-generation imaging to monitor therapy. It also makes no recommendations on the oligometastatic state, aside from the upgrading that we just talked about. It makes no recommendations on the number and locations of lesions, and it makes no recommendations on the use of next-generation imaging to guide focal therapies. So, for example, it continues to recommend the use of bone scans, CT scans, and morphological MRI for metastasis-directed therapy, saying that this is completely appropriate. And this is on the basis of studies like this, the Oriole study. In this study, 54 men with oligometastatic prostate cancer on conventional imaging either received stereotactic radiotherapy or observations. And you can see that people who had cyberknife radiotherapy had a better progression-free survival than those patients who were just observed. But you'll notice that about half of the men had PSMA PET-CT lesions that were left untreated. How did these men do? It turns out that cyberknife therapy had the greatest benefit when there were no untreated PSMA positive lesions. So you can see here is the failure-free survival when there were no untreated lesions, but if you left lesions behind, you were more likely to fail at an earlier time point. So distance metastasis-free survival was greater when there were no untreated lesions, and men who had no untreated lesions had a lower risk of a subsequent metastasis. These data emphasize that all the disease that is visible either on conventional imaging or on PSMA should be treated, otherwise patients will suffer detriment. Now let's talk about castration-resistant prostate cancer, particularly the polymetastatic state. The ASCO imaging guidelines say that PSMA progression should not be the sole reason to change therapy. If you see PSMA progression, then you should do conventional imaging to follow patients over time. But it also says that when there is a high clinical suspicion of progression with otherwise stable conventional imaging, you can think about using next-generation imaging, particularly in a clinical trial. And that is because there are numbers of instances where patients will be progressing clinically and you don't see anything change on imaging. So, for example, in castration-resistant prostate cancer, you can have a deteriorating clinical state without a changing bone scan or CT scan state in up to 40% of patients with abiraterone, and these people have a worse prognosis. So here's an example of somebody with unequivocal clinical progression. 86-year-old man, metastatic castration-resistant prostate cancer, being treated with immunotherapy and a PARP inhibitor. He's on a clinical trial, so we've done regular CT scans, which were called stable prospectively. Unfortunately, he was clinically progressing, was taken off the clinical trial, and you can see how his PSA increased from 141 to 401. And if you look at the whole body MRI scan, which was repeated, you can see he is definitely progressing. Furthermore, the ASCO guidelines also say that if you've performed next-generation imaging at the baseline, then you can perform it for serial comparisons to assess the degree and extent of disease progression. And here's an example of that application of next-generation imaging, initially for hormone-sensitive disease and then for castration-resistant prostate cancer. So you can see in the hormone-sensitive state, when the patient was being treated with ADT alone, we were using imaging to follow the progression of the disease into the retroperitoneum. So by this time the patient is becoming castration-resistant with the emergence of lymph nodes in the left axilla, and this is the PSA trend. You'll see that he was treated with abiraterone in the castration-resistant state, at which point we begin to see a discordant response. So, for example, you can see that the retroperitoneal lymph nodes respond quite well, but in fact groin lymph nodes and pelvic sidewall lymph nodes don't. And he begins to develop bone metastases also. So this is classical discordance that is developing, and you can't tell that discordance is happening on the basis of a PSA test alone. Combining the APCC guidelines with the ASCO guidelines, there is now increasing recognition of the role of next-generation imaging for therapy monitoring. So for hormone-sensitive disease, bone scans and CT scans are still preferred on a schedule that is determined by the rate of change of PSA. However, for castration-resistant prostate cancer, when there is a high clinical suspicion of progression, despite negative or unchanging conventional imaging, you can use next-generation imaging to find out what is going on. And next-generation imaging can play a role if you've already performed it at baseline for subsequent comparisons to assess the onset of progression. Okay, let's sum up the indications for next-generation imaging in advanced prostate cancer. For newly diagnosed high-risk locally advanced cancer, when conventional imaging is negative or suspicion and clinical suspicion is high. For high-risk biochemical recurrence, when there is negative or equivocal conventional imaging. For metastatic hormone-sensitive prostate cancer, to clarify disease volume and distribution, when upstaging would affect therapy choices, including the use of metastasis-directed therapies. For M0-CRPC, not very clear what the exact role of next-generation imaging is at the moment. For castration-resistant prostate cancer, it should be offered when there is high suspicion of progression despite a negative or unchanging conventional imaging. You can do next-generation imaging at the time, or if you've already performed it at the baseline and you want to follow the patient serially. Okay, let's now get on with the cases.